MHA chose to celebrate Bipolar Day celebration today. That is why we are having this virtual seminar of an important topic: quality of life and functioning with bipolar disorder, being positive and supportive. Bipolar disorder is a very difficult disorder, quite distressing for individuals who have this condition. It impacts difficultly in every aspect of their life: school, work, family relationship, family, and all that. But then again, studies, research have indicated, have supported that psychosocial support really helps in the quality of life and the daily function of individuals with the bipolar disorder. That is why we are discussing this topic today: quality of life and functioning with bipolar disorder and being supportive and positive. Ladies and gentlemen, before I go on, as usual, let me share the housekeeping rules with all of us. If this is your first time, the moment you join, do well to mute your microphone. Again, during the question time, indicate by raising your hand as usual. I'll call it out and you make your submission. We are going to discuss mental health. So I implore all of you to be as sensitive and empathetic as you can be in your questions, in your comments, and in your overall submission. Finally, let me add that Mental Health Authority has a helpline that we can call into and get psychological first aid. So you can please note the number down in case you need it or somebody close to you need this number. You could help that person with our helpline. And the number is 0800 678 678. Let me repeat the number again: 0800 678 678. Today being, should I say, celebrating the Bipolar Day, and it's important to Mental Health Authority. We have some of our directors joining us. I would introduce them while we go along with the program. But you would all bear with me that bipolar disorder, as a disorder in itself, have received some sensational reportage in our media, being on social media or even being on the traditional media. And that has contributed to the stigma towards the condition, worsening the quality of life and the functioning of persons that have bipolar disorder. But like I said, being supportive and being positive towards these individuals is quite helpful. So today we are going to learn a little bit about the condition and how we can be supportive when we come across individuals who have this condition. And with me to do justice to the topic, I have professionals who are well-versed in practice as well as in academia to help us digest the issue. So I would introduce them to you. First, we have Dr. Pearl Edunyako. She is a specialist psychiatrist at the Komfo Hospital, as well as a lecturer at the KNU ST, Department of Psychiatry, I hope. Ladies and gentlemen, I present to you Dr. Pearl Edunyako. Pearl, hello, how are you? Unmute yourself and tilt your camera a little bit. Unmute yourself. Yes, let's hear
good.
you.
Can you see me?
Yes, I can see you.
Great.
Good. Thank
Good
you for
afternoon
coming.
to everyone. You're welcome. It's a
Good,
pleasure.
good, good. Let me do the ladies first before I come to the gentleman.
Mm.
So next we have Miss Hannah Aboyinga. She's also a clinical psychologist at Accra Psychiatric Hospital, as well as a deputy chief health tutor. Hannah, how are you today?
Very fine, Dr. Tata. And it's an honor being with you this afternoon.
Fantastic, fantastic, fantastic. You're most welcome. And finally, he's no new face to this seminar. He's been with us quite a few times. Dr. Jonathan Odame is a clinical psychologist as well as a lecturer in the Department of Psychology at the University of Ghana, Lagos. Dr. Odame, you're welcome.
Thank you very much, Dr. Atten.
You are looking young and fresh. Where have you been? It's been a while.
Thank you very much.
Wow. Okay. So now that I'm done with our introductions, let's get the ball rolling. Let our participants understand what we are talking about. Let's start with the basic of understanding what bipolar disorder is. Hannah, you are in the play. Pearl is also in the place, but let me start with you so that Pearl can top it up. What is bipolar disorder? How does it manifest itself? What are the risk factors that would make me prone to this disorder? Which group does it often affect? Just give me a gist about that, then Pearl will top it up.
Okay.
Go ahead.
Okay, so good afternoon to listeners. In simple terms, bipolar, maybe I would not want to bother my listeners with the jargons, but once we say bipolar affective
make it
disorders,
as simple as we can understand.
Yes.
Simple terms.
Yeah. So simply we're talking about mood swings. Once we talk about mood swings, somebody will say that everybody do have swings at a point. But these mood swings are what we term or what we think they are to the extreme, that the person is moving between the extreme form of sadness, which we talk about depression, to an extreme form of happiness or euphoria or elation, which we term mania or a manic episodes. And these swings are very debilitating, that the person seems not to have a stable life, and usually the person might not even get to know the effect of it, but people around this person might have difficulty in understanding what is happening to this person. So for me, in simple terms, we're talking about mood swings that are to the extreme forms that we think it affects an individual daily life, which the topic is talking about quality of life, which the person might have problems in terms of family relations, the person might have problems in his school activities, work, or with other social functioning.
That's all right. Let's see if Pearl will top it up for us.
Okay.
Pearl.
Yes, thank you so much. And I like the simple way she puts it, because that's typically how you would recognize it in someone who is experiencing it. But to bring in the technical components to it, or to outline it clearly so that we are able to distinguish It's completely bipolar affective disorder. It's a mood disorder, or in simple terms, it is a condition. It is a chronic condition, and it basically affects your emotional states. It affects your energy level, and then it also affects your activity level. And as I mentioned, it is a chronic condition, and it affects your broadly your emotional functioning. So we find that persons with bipolar affective disorder, they tend to exhibit two variations of disturbance in these three areas that I mentioned. And when we say someone is bipolar, it means that this person sometimes swings to the high energy, high emotional state, high activity state, or the person ends up on the low activity, low energy, and low emotional state. And these two extremes are all on our emotional spectrum. So people with bipolar will be seen on either of the extremes during episodes. And to help us appreciate it better, it actually means that disorders that affect our mood can either be unipolar, which means you are only on one side of the spectrum. And when you're on one side, you could be on the low energy, low emotional state, and low activity state. When you are at that point, then we say you have depression. And when you're always experiencing the symptoms for the other end, where you have high energy, high mood states, and high activity states, then we say you have a manic disorder. So people with bipolar often experience these two disturbances in each episode they have. And to further help us, people who have bipolar affective disorder do not always present with both sides in each episode. We have those who have what we call bipolar 1, and we also have those who have bipolar 2, and even we have bipolar 3. And the differences between these is that even though they show different variations, one group only experiences the high picture all the time during their episodes. So each episode they have high energy, they have elevated mood state. That is, they feel happy and more excited than their usual states. They have more energy than usual. And so even the way they perceive themselves, the way they view their abilities and their capabilities is on the higher side than their usual. And those who are in this category only experience this type of variability. The other group experiences both. So they will have one episode with high energy or the manic picture, and then in another episode, you see them with a low energy, low activity state. And for this category, we actually have another variation where they will not have so high energy, high activity, and high mood states like you will see in the manic end of the pole, but they are in a slightly elevated above the normal state. Then we have the type 3, where you have an increased rate of experiencing these changes. And just as how Hannah was saying, in all these various forms of bipolar affective disorder, there is a disturbance in functioning. Typically, when we look at the states that we refer to as the hypomanic states, just as the name goes, they are not fully in the manic picture where they can't sleep, where we say there's decreased need for sleep, where they will not sleep the whole night, and yet during the day, unlike the rest of us, they will not feel the need to sleep. But they'll go on and on and on, and they will not rest at all. So there's a high energy state. and they have an elevated mood state. So they are very excited. They show less control in their emotional expression. So they can be very irritated about things that previously they will not be irritated about. They go overboard in their interpersonal relationships. So if you interact with them, you'll find that you may not have known them since you came to this earth, but they are over familiar. That is to see that the first time they meet you, they relate with you as if they've known you from Adam. And they have what we call elevated self-esteem. So they believe themselves to be more than what they are actually. And they tend to have overvalued ideas. So their ideas are not completely impossible, but they are far stretched beyond what is possible. And they also engage in high-risk behaviors. And because there's a reduction in the ability to control themselves and also in the ability to accurately determine their limits, you find them engaging in a lot of risky behavior. So bipolar is the middle point of a chronic mental health condition that principally affects these three key areas of your functioning.
Fantastic. I mean, with this, we now know what bipolar is. At least we have the basic idea. If we see somebody behaving in a certain way with regards to moods at the various end of the pole, it has to be one of them, extremely one. Okay, so Dr. Dami, let me come to you. I see this signs. Now I'm worried and I want to help this individual who thinks that he or she is fine and so refuses to let me help. Let me help. And the person is refusing. How can I get the person to seek for help?
Okay, thank you very much, Dr. Atta, our two groups of persons for the detailed presentation and lectures they've given to us for us to understand the meaning of bipolar disorder. Basically, oftentimes when it comes to these disorders, the people who have them may not see the need to seek help or may not appreciate the relevance of a psychologist or psychotherapy in their lives. So oftentimes it is people that we refer to as significant others who would come and even tell them that you have to see a psychologist or not, because they accept their condition, they may accept it as part of their life. It's like someone who has been raised in an urban area. The way he sees things or she sees things may be different from somebody in a rural area. So most of the time, they themselves may not see the need to see a psychologist unless they get educated or they become aware of their condition. So as it has been explained, of course, bipolar is mood swings where one person exhibits high levels of anxiety or excitement at one point, and at the next moment, the person is so low or the person is very, very, very depressed. So as a psychologist and as a therapist, first of all, if I'm to help such a person with such a problem, I would first of all ask the person how long he or she has been having these mood swings. Because from literature, bipolar disorder can start at any point in time, irrespective of your age. But from scientific journals, it can start from the age of 25 years. That is when people are in their late adolescent stage. So I'll ask the person, have you noticed these mood swings? And can you describe how these high or low moods look like? And also, if the person has any problems in their sleep patterns or has any problems in their eating patterns. And also find out from the person as a psychologist if any of their family members have this mood swings or mood disorders, and whether the person has experienced any stressful life events in their lives. So as a psychologist—
Dr. Adame, please hold on for me. I'm a lay person. My neighbor, my brother, my sister is exhibiting these signs and symptoms, and I feel that he or she needs professional help. But this individual refuses to accept the help that I am providing. So how do I convince this individual to follow me to come and see you?
Yeah, so as I was saying, the person himself may think it is okay to have those behaviors, but you, the person, you are seeing it as a problem. So there's a need for you to educate the person that all of a sudden there are some points that you are so excited, you are my friend, but there are other times that you seem so down, you seem so depressed and the rest. And I think that there's a problem. Even if you think there's no problem, let's go and see a psychologist for an assessment. So the person should be educated on his or her behaviors, the mood swings, and even the fact that it may even be affecting his or her functioning. So if the person is made aware that this is the problem, then that is where you, as the person, can provide the support by taking the person to see a psychologist. In fact, you made mention of psychological first aid, that there are some helplines that people can call at the authority level. So I believe that as a person, if you see that your friend has these symptoms, you can provide the immediate support, that's a psychological SA, by referring the person to the right sources. If the person is resistant, then you draw the person's attention to certain behaviors that he or she is exhibiting that you think that may cause a problem, and there's a need for a psychological intervention.
Thank you very much. Hannah, would you like to add something?
Yes, please. Okay, to add on to what Dr. Adame have just said, usually this is the challenges we face as clinicians. In a psychiatric hospital, most of us think that it is not something to mention, that let's go see a psychiatrist. I think of now what is better is a psychology people think is better, but most people don't think so. So as a family member, you only need to create an environment that is trusting for this individual. Let him feel accepted. And that you have to also assume a non-judgmental position. Mostly with people we identify to have problems or challenges, we are quick to stand at the defensive side to say you have a problem. But once you create the environment that is enabling for this person to feel accepted, you don't feel judgmental. And as Dr. Adame said, once you try all this, the next thing is to see whether we could get the helpline. I think most of the psychiatric hospitals we have, MHA has a call-free helpline. Across psychiatry, we have lines that you could call to seek first aid. Time we have some Anchor Folk, Mercy, anyone. Or even if you have a relative or a friend who is close to a clinician, you can always start that way. But it's really difficult, as the question have been posed. Practically, we see them every day, and then it is difficult to get people to accepting that they have challenges and they need help, especially when it comes to persons with bipolar. Mostly when they swing to the depressive episode, it looks understandable because they feel it. But most people, when they are at the manic episode, they see the results. They are working, the self-inflicted words, and then the risky life behaviors that they think that they are getting results, will not let this person, because he feels that he's getting the results and he wants to get more. So it's difficult to get them, but with the enabling environment, trusting and being non-judgmental, we can always help them. Thank you.
Thank you very much, Hannah. That being said, I did mention earlier that today we are commemorating Bipolar Day. We have some of our MHA directors. So let me quickly say who is there. We have Dr. Nanaya Dobia Brown. She is our technical director. We have Mr. Evans Kelly. He is our financial director. Ms. Fidelicia Bakobie, she is chief pharmacist. Ms. Priscilla Teria, Deputy Director, Community Care. Lydia Kukwasake, she's also one of us, a community nurse. When the others join, I would acknowledge them. There are a few individuals that I see who are quite regular here, and so I would also acknowledge them as we go along the program. Pearl,
Yes.
if I bring somebody to your consulting room,
Yeah.
you would definitely ask me questions. Even you would ask the individual who has a problem question. You would definitely ask me questions. But perhaps I may have taken particular notice or not. So by way of educating us, what are some of the things that we need to look out for me who is bringing the person, so that these are the questions you'll be asking me. So by way of providing you with more information to assess the situation. So what kind of questions would you be asking me, not the person who will seem unwell? I know you asked both of us questions, but what are the things that I who is presumably well, what are the things that I need to look out for? What are some of the questions you'll be asking me?
Okay, so thank you. This is a very important aspect of the evaluation phase in the determination that someone has bipolar affective disorder. And this is one of the greatest clinical challenges that we face in diagnosing mood disorders. And it is so because there are two key things that you need to be aware of, that developing mental health disorders, specifically mood disorders, is not a congenital situation. So the assumption that people who have bipolar were born that way is an erroneous assumption. So typically you look for an abrupt onset of symptoms. So is either the person has had the symptoms lasting for more than 2 weeks, which means that typically in your assessment, if you are asking the person who is accompanying the affected individual, or you are asking the person who is experiencing the disturbance, you want to establish by asking clear, open-ended questions that will help you determine there's an abrupt onset of symptoms. And the areas your questioning will go into encompasses, yes, the nature of the onset, whether it was sudden, which is what we expect, the duration of the changes. I mentioned changes in 3 main areas: mood state or emotional state, energy level, and activity state. So you want to ask questions bordering over these 3 key areas. And you're asking questions with regards to, first, the nature of the onset. It should be abrupt. And most of the time, the individual themselves can give you a landmark of when they notice the sudden change, whether their temperament predisposes them to be the calm, quiet person. They will notice that the dip is not their usual state. And if even it is someone who is a high energy, outgoing person, and they are even in the manic phase, they will also be able to tell you when they notice an unusual or abnormal surge in that state. So the nature of the onset first. Then I want to ask questions about the duration. I mentioned a state noticeable in bipolar, which we refer to as hypomanic states. And for those in hypomanic states, all you need is just 4 days, 4 days of exhibiting the change in that state for you to be able to say that this person is in a hypomanic state. And so you're looking at 2 weeks or 4 days of exhibiting these. On the extreme end, if this person has had this change and it has gone on for a while, and therefore even the people around them are beginning to accept that that is their usual state, that is where the accompanying individual plays a critical role. And so in taking your history, you want to ask questions from people who have known this person from an earlier age and are able to determine that the person was not at this level. And so there was a change. So you ask for the history of the onset. And then it's also important to find out if there's family histories. And that is because mood disorders have been found to have a high risk of being genetically propagated. So the questioning would be to determine whether there's a first degree relative who has also exhibited similar features, and that will give you a high index of suspicion that you are dealing with a mood disorder, and also, for that matter, a bipolar disorder. You would also want to determine that when the episode began, it stopped. So without any intervention, the episode would end and there will be complete restoration of the person's previous state of functioning. If you are not able to establish that this individual had their symptoms completely resolved, then you are not dealing with a bipolar affective disorder. Then you might be dealing with some other mental health conditions which can have associated mood disturbances like schizoaffective disorder. In schizoaffective disorder, you will see all the features of maybe a manic presentation or a depression presentation existing together with schizophrenia-like symptoms. And so it is very important that if you want to diagnose that someone has bipolar, you should be able to establish in your questioning that when the episode began, it was abrupt, it went over a period of time, and all the symptoms resolved, the person returned to their pre-morbid state. That is, the person returned to how you knew them to be after that short period. And it tends to be chronic. So it is cyclical. And so the extreme group, which the DSM mentions as the type 3, that is where you can have the individual experiencing more than 4 to 5 episodes in a year. And that means that they will have as short as about 2 months to 3 months interval between episodes. And that is the most severe version of the disorder. So it is very important that in your questioning, you bring these key features up so that you can tell that this is bipolar affective disorder. And then to be able to help the person receive the help, once you ask these questioning, the person will do introspection and self-evaluation, and then you would be encouraging insight. The beautiful thing about bipolar and mood disorders is that unlike the typical myth that we have that makes us think that people with mental disorders out of their insights, they are aware of the disturbance. If the person is not aware of their disturbance, then you might be dealing with schizophrenia or schizoaffective disorder. So have insight, and they will tell you that yes, even when you have brought them back to their pre-morbid state, they will come and tell you that, in fact, doc, when you brought me back to my normal state, I don't have as much energy as I used to have. I'm not as excited as I used to be, and I can't work at the speed that I used to work, and I actually was beginning to enjoy that state. So you would realize that people with bipolar usually have insight. People with bipolar do not always have impaired functioning. In fact, there's an increase in goal-directed activity. So your typical bipolar disorder patient who has more of the mania pictures will wake up at 2 a.m., will clean the house, will prepare different foods, and be awake the whole night, and during the day will still not feel burnt out. So these are the 3 key questions that, in addition to other questions that you want to ask, the onset of the symptoms, there should be a clear mark for determining when the symptoms.
Okay, I think internet issues, the onset of the condition, the history, if there is a family
began
history.
Yeah, the duration of the episodes, and then a complete resolution of symptoms in between episodes.
All right, thank you very much. Thank you. That's quite.
And once you do that, yeah.
Thank you very much. That is quite extensive. I mean, by the time we are done with this, we all become professors in our own small way. Dr. Dami, let me come to you about attitude. There are common stigmatizing and discriminatory attitudes that we display towards this individual. It's common, so we see them as normal, but invariably they are harmful to persons with the bipolar disorder. Can you please point out some of these attitudes to us and how harmful they are to the individuals?
Yeah, thank you very much, Dr. Atten. Yes, it's true. Sometimes there are societal stigmatization and certain discriminatory attitudes that we exhibit towards people living with bipolar disorder. In fact, people think that, for a better language, or to excuse my words, people with this condition are unpredictable, or they are going insane, or they are going crazy because of their mood swings. Even to the extent that there are some people in relationships that either their boyfriend or their girlfriend has these mood swings or these disorders, and it sometimes even scares them, especially when they are in their depressive states or their manic state. So when these things happen, it makes them feel so much isolated and so much misunderstood, because whatever is happening to them is a mental condition. And from what the doctor said, it is a chronic condition. So the person will always exhibit those kinds of behaviors. And of course, as she also said, it could be that in a year, the person will exhibit about 5 episodes of these mood swings. So it is important that we understand the condition called bipolar condition and a character flaw. Like somebody is intentionally doing that today you are happy, tomorrow you are sad, today you are this, today you are that. If we don't understand them, that is where it will cause a problem. We tend to stigmatize them, we tend to isolate them, and it also affects their self-esteem. So there's a need for us to develop a positive attitude towards people who have bipolar disorder, even as we celebrate bipolar disorder worldwide today.
Thank you very much. In that said, Hannah, let me come to you. You are a clinical psychologist. What specific role does would the clinical psychologist play in the life of a person living with bipolar? What specific role?
Okay, thank you, Dr. Atta. As Dr. Pearl said, it isn't that people who have bipolar, they lack insight. They know what it is, but mostly, as I stated earlier on, once they are at the manic episodes, they enjoy what they gain. They are able to get results, and they are able to maneuver. The energy levels are high, so they usually will not want to get off it. As a psychologist or a clinical psychologist in taking care of clients with bipolar affective disorder, my goal or main aim is to help them understand and accept their disorder. And once you understand and accept, then you will be, it will require of you to also adhere to your treatment. So as a clinical psychologist, you need to get clients to accept their condition and then to the management of the condition. Once you don't have them involved, then that is where we have the problem. Like we said, they have the insight, but it's now for them whether they accept that this is what is happening and it is a disorder or not. And once people have doubts about whatever the professionals are saying, then adherence or compliance is a problem. So as a clinician, that is one. Another that the clinical psychologist will help them is how to identify symptoms. Usually you might not be able to meet them at the episodic level, but usually after post-episode, you know whether I'm getting a relapse, I'm getting an episode, and how to curb it. Another one that as a clinician is to also help them manage their emotions. Dr. Pearl mentioned earlier on, I think her first presentation, she mentioned that we have emotional involvement. And these are the things that you have to take them through. We have something we call emotional tolerance skill, so that this person will know that once I'm faced with these emotions or these problems, this is how I will manage them. But it is not to say that once I have bipolar, when I'm faced with difficulties, I let everybody know, okay, for me, I'm sick, so this is how I'll handle it. But we teach them tolerance skills as to how to fit into society. And that is through psychotherapy. We help them with their families to also see how they can unify, or there will be cohesion in the family. Usually they're not, when we have patients like this at home, it is always a disjointed thing in the home because nobody can predict. And at times it's also for family members because they don't even understand that this could be a disorder. Then the labeling starts, or he's over ambitious, he's that. And then once you have it, to educate clients and family on the condition. And an important thing that we usually will want to teach family is the communication. So you want them to understand that you don't have to over-involve yourself, or when you are communicating with this person, you have to communicate clearly. The person is not less than a human being. So usually there are these terms of high expressed emotions in family. So families that have high expressed emotions, you always see that patients do not do well. And it can even cause bipolar, and it can also be a perpetuating factor in the event or in the cause of bipolar. So you want family to understand the dynamics of expressed emotions. So other families or members will want to think that I need to protect this person. So the over-involvement in it. People pass critical comments that are not worth it. So in psychotherapy, you might want to address all these concerns. So as a clinician, these are some of the things we do. So usually the management or psychosocial management is focused on the family. So we have some family-focused therapy that you want to involve the client and the family so that we can all be on the same page. There are others too that maybe not just the family focus alone. In addition, you could do the cognitive behavioral therapy sessions. Once you identify problems, you want this client to understand and connect her thoughts and her feelings and her behaviors. As we have expressed earlier on, that the symptoms, we have the involvement of behavioral, we have cognitive involvement, and we have the emotional involvement. So you could also do the cognitive behavioral therapy for the client to understand. Most people also have problems in their personal or interpersonal relationship. So you could also look at how you do the interpersonal therapy to help this client, even if it's not within the family unit, but with the social, maybe friends, work, school, as to how this person might integrate well into the society. And these cannot stand alone. So usually we say that the psychosocial management is an adjunct therapy or supplementary to pharmacotherapy. So clients at times will want to misconstrue. A lot of them will come and tell you, oh, I think I don't need a psychiatrist. I want to see the psychologist. But it is important for us to know that there have been other biological underlying, and the first or effective treatment is in combination. So psychotherapy or psychosocial interventions will augment or supplement the medications or the biological basis of bipolar affective disorder. Thank you.
Thank you very much. I said today that by the time we are done, we are all professors in bipolar. Pearl, so in addition to helping the individual accept the condition, teaching them to manage their emotions, bringing in the family to learn how to communicate, helping the person through therapeutic interventions and all that. Is there anything else that the psychiatrist also does to support the individual with such a condition?
There is quite a lot. Just as I mentioned earlier on, the psychiatrist has access to, let me say, the full repertoire for the various variations of the disorder, and therefore conducts a complete evaluation of the disorder. And that is very critical because currently we've moved away from the disease model for disease management. We've moved away from the social model. We've moved away from the biological model. What we are looking at is the biopsychosocial model. And that is because we've redefined the definition for health to include not just physical well-being, but physical, mental, and social or spiritual well-being. So the management of bipolar is a three-pronged approach, which means that it requires a multidisciplinary interventional approach to the management. And it begins, I must say, with the biological investigations. And that is where a thorough history is very critical. And in the history, the goal is to determine the causes, or what we call the etiological fact, because the risk factors being conditions or endocrine disorders that can present with symptoms that can easily be mistaken as a mood disorder or even a bipolar disorder. Conditions like Cushing's disease, which affects adrenal glands, so many other endocrine conditions, even our simple thyroid, hypothyroidism or hyperthyroidism can lead you to show symptoms like you are in the manic phase or you are in the depressed phase. And so if a clinician and the person is not a psychiatrist, you might assume you have an endocrine disorder and be treating you in the endocrine pathway when it is a functional disorder and it's a mental health disorder. So the psychiatrist does the full-scale evaluation to rule out all other organic causes. Even vitamin B12 deficiency can present with symptoms that can look like a bipolar affective disorder. So a complete history covering your whole life history, family history, developmental history, your personal history, psychosocial functioning, pre-morbid functioning, substance use, because some substances you use can predispose you to exhibiting mood symptoms. And then also some behavior or personality disorders. About 20% of people with bipolar affective disorder have been found to have underlying borderline personality disorder or dependent personality disorder or narcissistic personality disorders. So your psychiatrist will do a thorough investigation and rule out organic causes, rule out either other psychological disorders that is, and then having established that this is purely a functional disorder and specifically a bipolar, the intervention, the biological interventions will consider certain factors. One, your age will be considered, your gender will be considered, And when we look at gender, we'll be looking at if you're a female, are you in the adolescent phase and you are experiencing these mood disturbances? Is it related to your menses? Because menstrual disturbances in hormonal functioning can mimic you having a bipolar disorder, and we need to clear that out of the way. Then if you're a female, are you in the reproductive phase of your functioning? If you are, then even the biological agents, which we further group into a mood stabilizer, which you need principally, the severity might require that we add some antipsychotics to it, because in severe conditions, you would begin to have some psychotic symptoms. So you might need, in addition to your mood stabilizer, an antipsychotic. And a lot of the mood stabilizers are anticonvulsants that we use. Again, if your bipolar presents with only the low angle of the presentation, that it means you have the bipolar, the one that presents with the depressive features, then even the choice of the mood stabilizer has to be chosen with that understanding that you are on the low end of the pole, and therefore you need medications that will bring you up again. And if you're on the high end, the manic pole too, the choice of mood stabilizers and antidepressants is very critical. Again, we are also aware that some of the mood stabilizers may have some impact if you are in your reproductive age. Let's say you are preconceptive, or if you are pregnant, your psychiatrist needs to be aware of this. And so some of the biological investigations in your
Pearl,
last, yes.
Pearl, hold your
Yes.
fire. Hold your fire. So if I am getting you, in addition to all that
Yes.
Hannah said, psychiatrists, you do biological investigations so that you could be able to determine the kind of mood stabilizers and all that these individuals do get, correct?
Yes. And
Fantastic.
then in addition to that, based on the level of disturbances that the individual is experiencing, like she mentioned, there is the need to have the psychologist come in. Sometimes there's the need to do some occupational therapy interventions for the individuals. And also the psychologist would help them sometimes with even the choice of career. Sometimes the risk.
Okay, Pearl, thank you very much. I think that you've given us enough information with what the psychiatrist does with regards to a person. Pearl, if you can hear me, hold your fire. Pearl, if you can hear me, hold your fire.
The full management that is necessary for you as the individual, and that management plan will include the biological, the necessary psychological investigations that should be in place, and also the necessary or anticipated psychological interventions would specifically come from the psychologist. Then on the social arm of the management is when you bring in an activation of the person's social support. So you call either their better half or their guardians or their parents or their teachers, any social support that is critical in restoring the individual's function. You activate that support system. Sometimes during the process, they lose their jobs, and you might need to help them by bringing in social welfare to help them find another job to do so that they can become financially self-sustaining, because that does affect compliance. Then also, as a psychiatrist, you need to put in place what we call an advanced directive plan, which is governed by what we call supported decision making. So you provide the client with all the psychoeducation, all the treatment options, all the intervention options. and you help them take the decision that is best for them as an individual, so that they can give advance directives and say that when I'm in my relapse state, don't give me this medication, don't send me to this person, don't do this. That's the advance directive. Your psychiatrist needs to help you put down that advance directive. And then also you need to also have that support of your team in all the arms of management, help you develop what we call a recovery plan. And we know that a recovery plan is not an endpoint. So we're saying that in mental health, recovery is not a single point, because if I started exhibiting the symptoms of bipolar when I was a teenager, my recovery goals will be different from when I am now an adult and I'm still bipolar. My recovery needs will be different from when I started off. And so recovery is a process. And so your psychiatrist, your psychologist, or even your
Okay, Pearl, I'm back. Thank you
sociologist
very
or
much. Pearl, hold your
rehabilitation.
fire. Pearl, hold your fire. Hold your fire.
Great.
You are too much on fire. Hold it.
Thank you for coming back.
Yes, I had internet issues, and thank you for holding the fort. Alice, it's quite good that you took over with that explanation. Now let's get into the psychosocial support itself. What we can do to support such individuals. We have less time. We don't have much time. So let's get into that. Let me start with you, Dr. Damin. I am working or living with a person with such a condition. What strategies do I need to be able to live or work with such an individual, for that individual to feel part of the working or the living process? What strategies would you recommend?
Okay, thank you very much, Dr. Atta. And okay, so as a psychologist, I would recommend certain strategies and certain steps for such an individual. First of all, I would tell the person, if he's on medications, to take their medications regularly.
No, please, you misunderstood me. I am working with or living with such an individual. What strategies would you recommend for me to be accepting, to be empathetic, and to be non-judgmental to such an individual?
Okay, so if you are living with such a person, of course, as you just said, and from the discussion so far, we don't need to stigmatize, we don't need to discriminate, you don't need to create that level of isolation where the person will feel very, very, very lonely. And you, the person, must also have that education and be enlightened on the condition, so that when the person is in any of the mood swings or episodes, you'll be able to understand the person. I don't know if it answers your question, since you are the one providing the support for the person.
Okay. Hannah, would you like to add something?
Also, I think that you should also be very empathetic, at least understand the person, there should be encouragement from family members and you yourself, so that the person will be able to move on with their lives and wouldn't engage in any harmful or risky behaviors.
Okay, all right. Thank you, Hannah.
Okay, thank you, Dr. Adam, for that. Just to add to what he said, we also need to be very critical about our comments and the way we talk with them. Mostly, we want to see them as vulnerable, and it sort of disadvantage them in decision making that will impact their lives, or that also impact the family setting. So it's always like they be relegated to the background, and then with the excuse that, oh, or yare, or they think. But I think that as somebody caring for somebody with bipolar affective disorder, regardless, consider the person as he is, because we know that once the episode is over, we get this person to his pre-morbid state. And these are some of the things, once we understand, we accept them and assume a non-judgmental position, we will always have them adhere to their medication, and then their treatment compliance will be high. And then we'll always have them get out of the acute phases and then prevent relapse. Thank you.
Thank you very much. Okay, I like that. Pearl, talking about medication. Pearl, are you there?
Yes, I'm here.
Okay, so briefly, talking about medication, this individual that I'm leaving is very non-adherent, and you as a psychiatrist, you are worried. What advice can you give me so that I would help that individual to be adherent to their medication? Family members and all that. What advice would you give to us, not the person who has the condition, that we can use to help the individual to medicate well?
Great. So the solution to that is in the psychoeducation that occurs as part of the management. And as I mentioned, the management is three-pronged: biological, psychological, and social. And the first aspect is the psychoeducation, which includes giving the patients or their significant social support members the knowledge about the cause of the condition and what the condition is, giving them the power to understand what is happening. And that understanding is that all of us have a brain, and our brain has a part that controls our energy level, our emotional state, and our activity level. Now, people with bipolar, they have a very normal brain if we take a CT scan. And this is what I tell a lot of my clients, and they are very good when it comes to compliance, because you give them the power to understand what is happening. You demystify the condition. So you tell them that your brain is looking like the rest of us. Your brain is perfectly normal in structure. The only challenge here is that some of the compounds that you use to help you maintain your true states have some fluctuations of the disturbances, and therefore the biological agent, which is the medication, is trying to restore that balance.
This is a conversation. Hold on. This is a conversation between you and your client. But I'm talking about me.
About compliance.
No, me, family member, knowing that my sibling is non-compliant. How do I help him to be compliant? So the science and the jargons and all that, make it as simple for me. What do I do to convince my brother to be compliant?
Yes. So just like how I was saying, I'm helping you understand why your brother is in that state. And that is the kind of background that you will need to give you the unrelenting support your brother needs. Once you understand that the medication is critical for maintaining the balance, you can be the one who is there 24/7 with your brother. Continue to encourage him to take the medications and remind him that this is not based on any spiritual something, but it is just like the food you need to function. Your brain also needs these things as its food that it needs to function. And so every word of encouragement that you can give that will let someone eat everyday food will be helpful in encouraging compliance. A lot of the times we do not help people understand the condition by demystifying it. When you break it down to this level, the person understands that, oh, I get hungry every day and I eat every day. Since you were born, you have not stopped eating. It's the same when you develop some of these conditions. You need these compounds, either externally or internally. In actual fact, when you eat, your body uses the food to produce these compounds. And that is how come you've been functioning all this while until you ended up in this state. And so you need to have the normal levels. And so you need to take your medication. It's as simple as that. It's as simple as saying, just as you need food every day to function, you need to be able to function as who you truly are on a daily basis. And therefore, it is either your body produces these things to help you function, or you get support. There's nothing wrong with support. And that support is coming in the form of the medication you take, the psychological support you get from your psychologist, the social support you get from me, your relative, being there to say that it's time for you to take your medication. Can you take it for me? You love me, take it for me. I love you, take it, so that we can go back to our everyday life. That is as simple as the support they need is. Being there for them, telling them, those who are going through depression in their face and they are feeling life is hopeless, everything is pointless, reminding them that life is actually beautiful. You see it this way because you have run short. And when you run short, you have to reboot. So pick it up and let's go about our normal life. That is as simple as what the support looks like. Sometimes when we are dealing with other mental health conditions where there's no insight, that is when we have to do the extreme of maybe putting it in their meals when they are not aware, so that with time, those conditions where there is no insight, when they gain insight, they'll be able to thank you. But for bipolar, where the insight is there, you point them to their symptoms, they acknowledge their symptoms, and you encourage them. And that's why Hannah was saying that the words you choose have to be chosen to encourage, to motivate the person to crave for normal functioning. It's as simple as that.
Thank you very much. Thank you very much. Okay. Now, family members, friends, neighbors, work colleagues, social colleagues. I want us to let all of us understand the key examples. For example, what kind of psychosocial support that they can provide, what kind of support that work colleagues can provide. So this is something that I'm going to share among the three of you. So Hannah, I want you to take care of family members, the kind of examples that family members can provide and how it will help the individual as well as the family, because everything that we do is it's a two-way thing. It benefits us in a way. Dr. Dami, I want you to take care of neighbors and friends, and Pearl, I want you to take care of work colleagues and social groups. So let me start with you, Hannah. After that, we'll open the floor for our participants to ask questions. So Hannah, give us examples, the kind of support that family can give and how it benefits the individual as well as themselves. Then Dr. Dami will take care of friends and neighbors. Then Pearl will take care of work colleagues and social groups. So Hannah, let's start with you.
Thank you, Dr. Atta. For family, what is expected or what I feel we could do for patients living with or clients with bipolar is acceptance and empowerment. As a family unit, you need to let this person feel he's empowered or he's being heard within the family circles. Going back to my previous statement of high expressed emotion. These are triggers and these are, or this is a concept that can cause or can trigger episodes. So family members are advised to be cautious or be mindful they choose and then be there. If it has to be supporting them to the clinic, maybe somebody will have to go with them, go through session with them, let them feel that, oh, just as we used to vibe when you didn't have your episodes or when you didn't have this condition, we still vibe in the same way. It makes them feel they are not alone in it. Also, as family, we're talking about adherence. Mostly when we have clients, if we're talking about bipolar, it is the attitude of family that will make clients not to be adherent to their medication. Most of them in my clinic will tell you that nobody cares about me. They feel I'm mad. They feel I'm too much. They feel it's intentional. So once it's like that. Okay, I will let them know that, so I won't take the medication. So we need, or family need, to be there for persons with bipolar affective disorders, make them feel loved, and then we make them belong to the family. Thank you.
Thank you very much. Dr. Dami.
Yeah, thank you very much.
Friends and neighbors.
Yeah, thank you very much. I believe friends and neighbors have an important role to play in providing support psychologically and socially to people who have bipolar disorder. And I'll take my opinion from what Dr. Hannah has said. You see, words are powerful, words can kill, words can heal. Sometimes the things we tell our friends can even affect them. There was a patient who I was treating some time ago, some years back, and I realized that she had bipolar disorder, and the friends had given her a name. You see, people who have bipolar disorder, some of them, it may have an impact on their sexual activities. So the people were taking advantage of her friends. And now my friend Ochadie, you see, that name Ochadie was having an impact on her. So when she is in the manic state, any guy who approaches her and tells her that, oh, you are beautiful, you are destined, she will just give in. So there's a need for family and friends to understand these things and to choose our words very, 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 very well. And also not to be judgmental in terms of their behaviors and the rest. And we have to be understanding and accept them. You see, we have to show empathy. You see, everybody is unique. The fact that you don't have that condition doesn't mean that you are perfect or you are okay. Everybody has his or her own flaws. So we should not be judgmental, and we have to even educate ourselves as individuals so that we understand the condition. And we should also encourage people with these problems to seek for treatment. And if there's any lifestyle changes as friends or family members, we can also offer that support. And we should also encourage our friends who have these conditions to engage in activities that will give them pleasure. Because you see, during the depressive states, they will be so down and they will be so much depressed. So for instance, if you have a friend who has these mood swings and he tells you that, oh, I'm not able to sleep very, very well, I'm not able to eat very, very well, I can see difficulties in concentrating, I can see difficulties in this, what you can do for the person, if you can't advise the person, please refer the person to a psychologist. And the psychologist would do all the work for you. That is, if you, the friend or the family member, you feel that you are limited in terms of your support for the person. Because the moment we start giving names, labeling people, you are like this, as for you like this, as for you like that, it later has an impact on them. You see, after the person relaxes and comes back to normal, all those ideas and all those words that were spoken to them, they think about it. When they go to bed, they think about it, and it affects them. So our advice is that we should be ready to provide support, and we should provide the right support as family members. If you think that you don't have the right support, please refer the person to a professional or a psychologist or a psychiatrist for treatment. Thank you.
Thank you very much. Phil, work colleagues and social groups.
Support. Yes, so to help our friends and family who have this condition we are describing, globally it's been found to be very helpful for the workplace or organizations to have what we call employee assistance programs. And these employee assistance programs should be designed to take care of all health needs of workers, which includes mental health care needs. And employee assistance programs are not supposed to be developed to victimize people who need help. It's supposed to be set in place to help with early detection of symptoms, to develop protocols, and to develop disability management strategies to help people who have one health condition or the other. So all organizations that are human institutions need to have a well-established employee assistance program with a disability management strategy in place so that people with bipolar can also receive assistance, which would include early detection, counseling support with regards to the nature of their work. Some companies actually do mental health checkups for their employees periodically in order to detect those who already have pre-existing mental health conditions, which could include bipolar affective disorder, or even to detect those who did not know that they were running the risk of having one disorder or the other. So early detection, and then there should be a strategy in place after the detection to support employees to receive the needed intervention that will maintain their productivity level at the highest. Because people who are bipolar, especially when they are in their manic state, they can do all the work and they can be very creative and they can be very reliable. So the settings where when we discover they have the condition, we feel afraid and we want to suspend them, or we want to sack them or victimize them, we have to change and provide them the support by leading the way. And when you have counselors available in an institution, they can be the ones who establish the rapport, who will build the confidence and the trust that will allow individuals to come forward and to access the help. And that is going to affect the productivity of the institution. Again, social support groups should be set up within organizations so that people from different aspects of health or with different problems can be part of these social groups and receive the support. Sometimes the cost of medication alone can push the person into non-compliance. And if you have employee assistance programs that offer financial support for your patient with bipolar, it can assist them to secure their medications or their psychotherapy sessions so that they remain productive throughout their working life. And again, the institutions and social support groups should help individuals make the right career choices in planning their work schedules. They should be considered. Those who are in the manic phase, they can burn out because when they are relapsed, they are very hardworking. A lot of times, human resource takes advantage of them and we all dump the workload on them. And they work until the crisis, then we abandon them. So as social support groups, as for, and consider that if someone has hypertension and you can't tell the person to regulate their blood pressure by themselves, the same way people with bipolar do need all the three areas of intervention to enable them function. So we should make it easy for them to access financial support if they are hypomanic and they have spent all their income giving it away because they are relapsed. So they are giving to charity what they have. When they are in their pre-morbid state, as I mentioned earlier on, one of the interventions is advanced directives. You get them to sit down and outline the things that we should do for them when they are relapsed, so that as soon as we detect they are relapsing, we have already established the chain of action. So we activate that pathway and they get the help that they need. And then periodically, human resource should be planning their recovery path with them. The same way we have appraisal forms and employee performance review that looks at your career projection. That employee performance review should also consider the fact that I have bipolar and these are my employee aspirations. And does my psychologist agree that it is realistic? Does my psychiatrist agree that it is realistic? So that HR can support you with it. And then you can be productive to the institution. And with the social support, we should not neglect them. Some of the myth is that once they have it, if you move with them for a long time, you too, you will become like them. No, it's not true. We should be there for them as a social support group. When we are taking decisions and they voice up their opinions, we should accept it. When they lose their temper, we should not quickly jump and say that, you are relapsing. No, like our psychologist mentioned, we should be accepting of them. We should integrate them into our society so that we can reap the benefits that they have to offer. And when we do that, we will have a healthier society. Thank you.
Thank you very much. Thank you very much. At this point, it is clear that psychosocial support from all of us is very important. I have a friend with us. She is a person with bipolar disorder. I'm going to allow her to tell us what psychosocial support have done for her in terms of her recovery. So she will do that. After that, those of us who have questions, you can begin to raise your hand and we can take your questions. Before the internet dropped me off, I think Ellie and Julius, you posted some comments. And when I came back, I have lost those comments. So if you could repost them, I could read them. Then if there are questions, we could ask them. So let me call Essie, are you there? Hello, Essie.
Yes, please, I'm here.
Fantastic, fantastic. So with you, I have been to several schools with you sharing your story, and you had to squeeze in your time to join us because you are still passionate about talking about it. And for that matter,
Indian hair. Please, I want to change my keys.
there's those with you are making noise in the background. But
Sorry.
but that being said, tell us what psychosocial support has done for your recovery train. Unmute yourself. Unmute yourself, Essie.
Okay, so for me, please, can you hear me?
Yes, we can hear you.
Okay, so for me, psychosocial support has come in many ways. In terms of, for example, my parents, they have made sure that I have always had medication. If I need to be admitted at the hospital, they've always made sure that they paid for my bills, make sure I don't run out of medication. When it comes to my doctors, they have always been there to listen to me. Anytime I make complaints, in terms of my friends, they've always been there for me. And emotionally, as a person too, I think I've been there to advocate for myself so many times. In terms of sometimes there are certain things that are happening that people may feel like you tell people, they may make you feel like you are crazy or something, but you are your biggest advocate. So these are some of the ways, and I think that it's high time that people take psychosocial support very seriously, because I feel like it's one of the ways that throughout our road to recovery, we get better. I think this year will be 9 years since I've been living with bipolar disorder, and psychosocial support has played a huge role. Even the support group I belong to, Psychosocial Africa, it's a community of other people living with other mental health conditions, including bipolar disorder. We have mental health professionals on the page. We have other people with lived experience on the page. It has played a huge role, because sometimes when people share their lived experience with you, it's able to guide you on your road to recovery and make you realize that there's always light at the end of the tunnel, no matter how cliche it may sound. So that's me. I'm not here, like I'm nothing without psychosocial support.
You are nothing without psychosocial support. You are something, my dear. Yeah.
No, what I mean is on my road to recovery, like you can't take that aspect out. Like it plays a huge role. Even my faith, yes, my faith has played a huge role, because believing in God, trusting in God seeing him take me out of my situation of depression to now being whole and well, I consider that even psychosocial support.
Thank you very much, Essie. Thank you very much
Thank
for sharing this aspect with us. We really appreciate it. Ladies and gentlemen, the floor is now open for you to ask your question. And so, Jonas is asking, can someone with bipolar be forced into having treatment if they don't willingly want to go for treatment? Hannah, can someone with bipolar be forced into having treatment if they don't willingly want to go for treatment? That's the question that I think I rephrased in a certain way.
Oh, okay. Thank you. So Jonas, as professionals, we owe it a duty to protect your life and also the life of others. Once family think that your life is at stake, so probably you've been distractive, they've seen changes, you are not going to work, you are not productive, and your life, there's been changes, then they think that you need help. We have to try what the other, I think, questions that we're answering, we're talking about how do we manage somebody who will not want to come family. So we could try talking to you, we could call you on phone and those things. Once it gets to a state that we thought, or maybe family think it's acute and your life is at stake, I think in Ghana, we have two types of admissions or treatment. We have the voluntary and the involuntary. So if it's possible that probably we think that you need treatment at all costs because we also owe you to protect your life, then maybe we'll have to go in for the involuntary treatment, which is guided by maybe a court order, making the request, and then the court determining that this person will actually need a treatment, and then we can commence with the treatment. I don't know whether I've answered your question, Jonas.
I think you have. Jones Kwesi Tabo is asking, how do you clearly differentiate bipolar from schizophrenia and depression? Bipolar is a disorder on its own. Schizophrenia is a disorder on its own, and depression is a disorder on its own. Bipolar has two ends, mood, where at one end, low depression, low self-depression, and the manic state. But then I'll leave that to the psychiatrist to respond to that. I'm not here to. So, Pearl, if you can help Jones briefly, just don't give him too much.
So I think Jones joined us a bit late. So clearly, Jones, to distinguish between the various mental health conditions you mentioned, I said the cardinal feature is that people with bipolar tend to have complete resolution of their symptoms. People with schizophrenia, and for that matter, schizophrenia types that do show mood disturbances, you will find that when the flare in their emotional state has subsided, the schizophrenia symptoms still persist. So if you talk to someone who has schizophrenia and their mood symptoms, their energy symptoms, and their activity symptoms have subsided, they will still have some lingering symptoms. They will not return to their previous states. But the person with bipolar will be experiencing changes in their emotional state, their activity, and their energy state for periods clearly defined. And then they go back to their old state. People with just unipolar mood disorders, that is, if they have just depression or mania, they will have their symptoms existing for a longer period. And when the symptoms resolve, they also return to their old states. So that is how we distinguish, amongst other things, from the different types of mental health disorders you mentioned.
Okay, thank you very much, Pearl. Angie says that someone with bipolar need to see a clinical psychologist each and every day, even though they see a psychiatrist. No, you don't need to see them every day. There is always a management plan, and the management plan will determine how often you see each and every one of them. Okay, there aren't any questions, and we've done extra time. So at least I think we've done justice to the questions, to the question and to the topic. Okay, Hargit has raised their hand. Let me allow her to. Hargit, unmute yourself and ask your question.
Please, good afternoon.
Good afternoon.
Please, I wanted to ask that can bipolar as well lead to another disorders like schizophrenia? Like having bipolar alone, can it escalate into another disorder?
Okay. Pearl, quickly respond to that one.
Yes, it can. And that's the reason why it is important that we treat people with bipolar. A lot of the clinical observations we've seen have shown that bipolar untreated worsens and leads to schizophrenia. And now we understand better even that with each episode that you experience, without treatment, the risks of your brain beginning to change so that you now come down with schizophrenia increases. So that is why it is important we emphasize the need for the 3 approaches to your recovery. So yes, bipolar untreated, even though it has the characteristics of resolving by itself without treatment, the episodes become shorter and shorter, and eventually cause changes that can lead you to develop schizophrenia. And nobody wants that for someone with bipolar. Yeah.
All right, thank you. I think we've done justice to the topic, quality of life and functioning with bipolar disorder. Being positive and supportive. So my facilitators, your final words with the topic and what we've done so far, your final words. Let me start with you, Pearl, so that we can be short. Hello, Pearl, can you hear me?
You haven't said who should start, so.
Pearl, you start.
Okay, so
The
key things I want us to have for takeaway is that bipolar individuals need intervention, and they need intervention in the 3 areas that ensure their continuous functioning and productivity. They need biological intervention, psychological intervention, and social intervention. Again, bipolar individuals need to have advanced directive plan as part of their management plan. So you need to sit down with all the stakeholders involved in your management, and with their support, outline what is an advanced directive, what you want to be.
I think Pearl is having challenges with her internet.
and what remission states, so that we are like we do not care about you. And you need to plan for every stage of your life. What is your recovery? Is not the absence of your symptoms to be what you want to stop. So any individual who has bipolar needs to have these things clearly outlined. And those of us who are part of their support group system, their therapeutic network, we need to help them develop these things so that we can reap the maximum benefit from them. There is treatment for bipolar. It should not curtail your dreams and your aspirations. You can be anything you want to be living with bipolar.
Thank you very much. Hannah, can you please share your final comments?
Okay, thank you. So I will start by saying that family is everything. And as we're talking about psychosocial intervention, family is the basic unit to provide psychosocial support for persons with bipolar disease. And to family, family have to be mindful the way they treat patients. And as I kept saying, any family with heightened emotional expression will always affect individuals, be it somebody who has a mental health disorder or someone who is not diagnosed. So as family members, we should be cautious of how we communicate and how we deal with each other in the family. And it will go a long way to help our clients to be compliant to their treatment regimen. Thank you.
Thank you very much. Thank you very much, Hannah. Dr. Dami.
Yeah, thank you very much. So my final concluding message is that living with bipolar disorder may be very tough, for the individuals and even people who try to provide support. But I believe that with the right support and treatment, people with bipolar can live very fulfilling lives and they can achieve their goals and their dreams. So it is important for everyone to learn about mental illness. Yes, and also to challenge the stigma around mental illness and offer compassion and support to those who need it. And we should always remember that no one is defined by their diagnosis. You see, sicknesses come and they go, and everyone deserves understanding and respect. Thank you.
Thank you very much, Dr. Dami. Let me quickly, Raphael, please, can we get a PowerPoint presentation copy? It means today is your first time. Every program that we've done, this is the 27th or 28th. All of them is on YouTube. So by Monday, it will be on YouTube. Just type in the title, MHA webinar, quality of life, function, blah, blah, blah. It will pop up. Samsung, can I walk to the psychiatric hospital to check my mental health status? Yes, you can. Charlotte, I've responded to your question, and that is all for the comments so far. So, ladies and gentlemen, thank you very much. For me, take home and being supportive has to be positive. And there are so many things we can do. We have to help them accept the condition. We have to empower them. We have to be there for them, let them feel loved. We have to be empathetic. We should mind the kind of words, the language we use for them. We should personally educate ourselves to be more informed about the condition, understand the condition itself, and how we can help them. We should encourage them to interact socially, more especially when they are on the low side, to interact socially and help them seek for professional help. In the workplace, it is creating an environment that is supportive of mental health that is most required. When that environment is created, stigma will go away. People can freely and frankly talk about the condition, support each other in terms of responsibility and all that. Then if there is a policy and the practice is established, which is established with a disability management in place in terms of EAP, Employment Assistance Program, the workplace will be a better place for all of us. So, ladies and gentlemen, these are the little things that we can do. You don't need money to buy them. There is the financial support that also really helps. But these are the little things in terms of attitude that we can do to support persons living with bipolar. On that note, on behalf of management C and management of Mental Health Authority, we want to say a very big thank you to all of you for coming, particularly our facilitators, Dr. Pearl Edunyakun, Dr. Jonathan Odame, Ms. Hannah Aboinga, Esenam Dra, for being excellent and fantastic, sharing your ideas with us. We really appreciate that. And our usual participants, we also thank you very much. We hope that the knowledge that we've acquired today, you are going to spread it so that our brothers and sisters out there will feel more accepting, will feel more loved, seek for help, and abide by their management routine so that they will recover and live a fulfilling life. On that note, I say a very big thank you to all of you. And World Bipolar Day for 2024 for today has ended. The program has ended. And the recording will be shared on YouTube on Monday. Just type in MHA webinar. Then you add the title of today's program to it, and it will pop up. It pops up with all others that we've done in the past, and you feel free to enjoy them. I think that the easiest way to do is to subscribe. If you subscribe, the moment you upload it, you get a notification that it has been uploaded, and you get to enjoy it. Thank you very much. Have a very good and a beautiful weekend. God willing, 26th of April, we'll meet again with another fantastic topic to discuss. Thank you very much. Have a good afternoon.
Bye-bye.
Bye.
Bye-bye.
Bye.